Hello and welcome to our Inclusive Health Talk. My name is Doreen Bestolaritas, and this is my son, Danny. And we're going to talk a little bit about Danny, otherwise known as Danny Boy or Mr. Smead. And I'm going to start off with talking a little bit about my story with Danny and how we've navigated through the healthcare system with different challenges that we've had throughout his lifetime. So Danny's being a little bit shy today, but let me tell you that Danny typically likes to rock and roll. He likes going to concerts. He likes going on outings and walks and picnics, and he's really missing his day program now with being out of his day program for so long. But anyway, Danny's 31 years old. And when I was pregnant with Danny, I did not know that he had Down syndrome. There was a test called an AFP, alpha fetoprotein. It actually came back normal, negative. So the only thing that I thought may go wrong during my pregnancy is that I was a critical care nurse working in the cardiac intensive care unit. And so I would sneak off into the bathroom when I was pregnant, and I'd take the Doppler and I'd listen to his heartbeat because I wanted to hear my first child's heartbeat. So I noticed that his heartbeat was irregular. And I did bring this to the attention of my obstetrician, who was a friend of mine, and he said, "Oh, you're just hearing the sounds of your own aorta. It's really nothing. You're just hearing a whooshing sound from your own aorta, and there's a lot going on in there." Anyway, needless to say, Danny was born premature, 1 month premature in November, and he was born with Down syndrome or trisomy 21, and he also had a congenital heart defect called tetralogy of Fallot. So with tetralogy, there's 4 abnormalities. There's a ventricular septal defect. There is what's called an outflow tract stenosis of the pulmonary artery. He had an enlarged right ventricle and what's called an overriding aorta, where the aorta lies directly over the VSD. So we knew right away that he was going to need surgery, pretty early. However, the surgeon wanted to wait until he was a little bit bigger, that his structures were a little bit bigger because he was very tiny. And the other thing is that we didn't have any specialists here in our own town, and we lived a couple of hours away from the Bay Area, and all of the specialists, and especially for open heart surgery, was in the Bay Area. So we had to wait. One of the things that I wanted to tell you about healthcare back then, and this was only 31 years ago, is that when I did have Danny, I really yearned for someone to come into the room and say, "Hey, congratulations on your new baby." But unfortunately, because there was something quote unquote wrong, we were whisked into a private room. Nobody brought the baby into us for at least 6 hours. We did not know that there was anything going on. I didn't even know he had Down syndrome. And so there was a lot of people whispering in the background and, looking in our room and looking at me. And we really didn't know what was going on. And it was actually a nurse who came in and said, we suspect he has Down syndrome. Plus he's got a pretty bad heart defect. So I never did hear from anybody, "Hey, congratulations on your new baby," or, "Here's the resources." So what do I do? Of course, like any other new mother who really just wants to see her baby and doesn't really know what's going on, I started crying. And so a social worker came in the room and she said, "You're pretty overwhelmed, aren't you?" And I said, "Very much so." And I said, "I don't know the first thing about, taking care of a child with Down syndrome. I don't even know what that means. I don't know if he'll go to school. I just have no idea what to do." And she said, "You know what? I'll be back in a few minutes. And this should help you." So what she did is she came back a couple hours later with a big vanilla envelope. She set it on my bedside table and said, just look at that when you're ready." Well, inside that packet was a very tiny booklet. And on the front of that booklet was a picture of a child with obvious Down syndrome. And the name of the book was Your Child is a Mongoloid. And that's all the education that was there that I had. I was not told about any community resources or if there was even another parent in the town that I lived in that had a child with Down syndrome. Everything was new to me. And the other thing that was in that manila envelope was paperwork to sign him away for them to, for me to give him up for adoption or to go to a foster parent. And again, I did not understand why or any of that, but that was just the way it was back then. So the first lesson I think I would give is for healthcare professionals when there is ever anything going on with a child with a disability is, hey, say congratulations on your new baby, but we know that there's going to be some challenges ahead, but here's some community resources. So really connecting to the community became a very big thing for us and also for support for us as well. Now in California, there are what are called regional centers, 21 regional centers. So if you're from California, you know that these regional centers provide information and case management for people who have developmental disabilities. And also under those regional centers, there's a law called the Lanterman Act. And this is something that we kind of learned later on in life, that under this law, the Lanterman Act, that once your child turns 18, the parent can no longer sign consents unless you have a durable power of attorney or conservatorship. So knowing the law becomes very important. And that was something that we just actually had to learn along the way, that I needed to get a durable power of attorney for him so that after he was 18, I could consent for medical procedures. So you can imagine with him having the cardiac issues, that by the time he was able to have heart surgery, he was already becoming symptomatic. And by symptomatic, he was having issues with feeding. He was turning blue. He was having what are called TET spells. And this was also something that I was not made aware of when he was a baby, because obviously, like I said, there were no specialists in our community. So all of the information that I could get was from, the doctors in the Bay Area, which I didn't have immediate access to every day. So Danny would have what were called syncopal cyanotic episodes, where he would pass out and he could only feed for short periods of time before his lips would turn blue and he'd get very tired. So we had to do very frequent small feedings with him before the surgery. Because these TET spells started to become more and more frequent, and I was pretty much freaking out as a new mother, we had to actually go in for urgent surgery then, where he had the repair of the tetralogy of Fallot. So while his issues are kind of medically complex, he's really very simple. So on the Maslow's hierarchy of needs with these kids, a lot of that background information might be a little bit scary, like, oh my gosh, he's had this, he's got, a congenital heart defect, he's got Down syndrome and all of the things that go along with that. And what else do we need to know? But what you basically need to know is that besides being medically complex, his needs are very basic. And all his needs are keep me safe, keep me warm, don't hurt me, make sure, my environment is conducive to my safety. And that's really all he cares about. So one of the most important things besides, connecting with family, connecting to the community, is that approach to care becomes very important. Now, he's very receptive, but he's not very verbal. He absolutely understands everything that's going on, but he's very visual. And all of his behavior, I can tell you, is communication. So right now he's communicating to me that he doesn't want to participate because he knows I'm talking about him. And Danny doesn't like anything negative. His first words, in fact, were three words: happy, happy, happy. Those were his first three words when he was a baby, and he has really maintained that for the duration of his lifetime. He's typically very happy. So whenever we're talking about anything like this, he gets a little bit nervous. Um, so when you approach Danny, he likes to be called his name and his nicknames, and he likes to know that you know everything about Toy Story, and it's all about, his Toy Story babies and things that he likes, and he will be very cooperative. And the other part of that is the reward. So if we are doing any kind of a procedure with him, whether it's an EKG, echocardiogram, dental care, anything like that, he has to know what's going on. He has to know what's going to happen next. He has to know the timeline that it's going to happen, and know the reward, which is typically we're going to go to McDonald's after this. So when he, like I said, when he knows all of those things, he is much more cooperative. So just going in and, having someone, grab his arm to do a blood pressure, or just putting a stethoscope to his chest, doesn't work for him. The approach is like, hey, Danny boy, how you doing? And maybe put the stethoscope on his nose, or, take a blood pressure of his baby first. And just even if there's a couple of those steps prior to him being cooperative, those are the only things that really will help him to be approachable and to actually follow through with whatever it is that we have to follow through with. And like I said, he is unable to really describe what his feelings are, so it's all behavior with him. He's very routine oriented as well. So this is why we have to prepare him for whatever procedure or anything we're going to do. And also do the same thing to one of his little Toy Story dolls, so that he knows that it's safe for them. It's going to be safe for me. The other thing to understand is that within every family, now that children are living at home with their families, and thank goodness we don't have the institutional setup anymore like it used to be back in the day. And so there's a lot of not only diversity within their disabilities, but also there's cultural diversity. And so we come from my husband's family is Greek. So probably every Greek person and their cousin was in the delivery room with me when I had Danny. And I'll, to understand some of these dynamics as well, and to, to be a little bit sensitive about that. I once took care of a patient who he had Down syndrome, and he was Spanish speaking only. We didn't know he understood Spanish, and he wouldn't get up on the bed. He would only want to sleep on the floor. And here we came to find out with his family that that his mattress was actually on the floor at home, and that's where he was the most comfortable. So we made that accommodation for him in the hospital, to be able to have that mattress down on the floor. Now, it's not always, a great thing for infection control or those kinds of things, but we have to be able to make accommodations. And with Danny, we make accommodations as well. He does not like to lay flat at all, which translates to he will not sit up on an examination table if we go to a doctor. Nor will he lay on an exam table if we're doing an EKG or an echocardiogram. So we have learned that we have to do some accommodation, which is let him sit up first, put those electrodes on while he's sitting up, and then as the lights dim down, then the technician for the echocardiogram can gently start to lay him back, and while they're talking to him, and this is part of the accommodation that he needs, as well as knowing that it's only going to be, he's only going to be in the dark room for about 30 to 40 minutes. Mom isn't going anywhere. His babies can lay next to him. And afterwards, we're going to go to McDonald's. So if all of those things are in place for, for him, then this is always a good thing for him. So the other thing with Danny is that because of his Down syndrome, he has muscle laxity. So he has had 2 knee surgeries, one on both legs, because his knees dislocate because of that laxity. Also, we found over the years that with his heart condition, the doctors have said, sewing his connective tissue is like jelly. So, so with all of these, medical things, we have to make sure that we think about what our lifelong plan is going to be, and then look at his medical care within whatever our plan and our approach is, for whatever is going to be the most therapeutic for him. So will it be therapeutic to, do open heart surgeries over and over again when we know that the longevity isn't going to be there, or his quality of life is going to be diminished, or he might have cognitive decline? So there's a lot of things that need to be discussed with families when you're talking about people that have some of these complex medical issues. A year after he had his heart surgery, he developed a fever, petechiae, multi-system failure, and sepsis. This was not something that was expected a year after his surgery, but we did learn a lot about what his heart could and couldn't tolerate. So over the years, because of as a consequence of the repair of the tetralogy of Fallot, over time, he has developed pulmonary regurg. So he's got a severe pulmonary regurg. So we have to be really careful if he's hospitalized, the amount of IV fluids he gets, and those kinds of things. And these are things that, mom has to really advocate while he's in the hospital, what treatments, how far we can go with things, what we know he can tolerate, and what is within, our goals for him. So fortunately, he did very well. He was in ICU for a month when he had that septic episode. And he has done very well for all these years. About 6 years ago, we did take him to Stanford to have a TPVR, which is a transcatheter pulmonary valve replacement, because as I said, as a consequence of that, the tetralogy of Fallot, now he's got severe pulmonary regurg. And so he's having some problems with being very tired, and we're always, looking for signs of heart failure and those sorts of things. But unfortunately, because of the dynamics of his heart and his anatomy is what is called technically challenging, that TPVR was not successful for him. So right now, our goals for care are to, number one, keep him happy, keep him safe, keep him from having heart arrhythmias, make sure he is treated if we see any signs of right-sided heart failure. And that, so this is where we're at. But like I said, on a typical day, he's very happy. Right now, he's ignoring us completely because I'm talking about him in the medical sense of the word. But we're very grateful for all of you, and for creating this network for positive change, to help understand people with disabilities, understand not only some of the medical issues that go along with their genetic issues, but also getting to know them as a person, knowing where the community resources are, supporting families and what their goals and aspirations are, and and just maintaining inclusive health all the way around. So I thank you, and I hope I will be seeing you soon, and we'll talk again. Thank you so much. Bye-bye from me. Bye-bye from Danny Boy.